The good news for diagnostic testing for baby boomers is that it is a single, one-time antibody test. These are available, they're inexpensive, they're reliable, and they're both highly sensitive, meaning they'll pick up over 99% of patients with hepatitis C, and quite specific. Obviously, the specificity or the likelihood of a false positive varies with how much risk factors the patient has. But that single antibody test, if it is negative, the patient can be reassured that they don't have hepatitis C and they don't need retesting unless they have risk factors. The confirmatory test is a direct test for the hepatitis C virus, and that is the next step. 85% of patients with a positive hepatitis C antibody test will have detectable virus and thus chronic hepatitis C. 15% likely either cleared the hep C on their own or in a small number have a false positive antibody test. So once we get a positive antibody test, we confirm it with the viral load testing, and any patients who are positive for both antibody and HCV RNA, the direct test for the virus, need to be evaluated for the severity of their liver disease and considered for treatment. All of the tests are reasonably reliable. That include both the formal blood tests, the finger stick tests, and then increasingly oral testing. The availability of the test and their applicability depends a lot on laws and different factors. In New York State, home testing of saliva-based testing is very difficult to do. In other states, it's more available. I think whatever test patients get, because the presence of the hep C antibody is so ubiquitous in all patients, the presence of false negatives are so low, it's much more important to get any test than to worry about what test you're getting. Once a positive hep C antibody test is obtained, this should be confirmed with a direct viral load assay. The HCV RNA, usually done by polymerase chain reaction or PCR, is a direct test for the virus. It should only be done in patients who are antibody positive. If the HCV RNA, or the HCV viral load as it's often called, is positive, the patient has hepatitis C. This should then be further evaluated with a genotype, which separates the virus into 6 subtypes, 1 through 6. Those subtypes determine the type of treatment that the patient should have. The subtype and the height of the viral load do not predict how serious the liver disease is, i.e., how much inflammation, that's what we call hepatitis. Hepatitis is Latin for inflammation of the liver, and how much scarring or fibrosis has been done to the liver. It is that progressive fibrosis or scarring that leads to cirrhosis over time. So at some point, after we've confirmed a positive test with the HCV viral load, we get the genotype to determine what treatment the patient would have, and then we have to stage the liver disease. Once we get a confirmed case of chronic hepatitis C, meaning the positive antibody and the positive viral load, you have to make a decision on linkage to care. With the newer treatments for hepatitis C and new non-invasive ways to stage the liver disease, in theory, anyone could treat hepatitis C. However, there are multiple regimens. They differ by genotype. They differ by whether the patient has cirrhosis or not. If they have cirrhosis, it's important to do liver cancer screening and other what we call cirrhosis healthcare maintenance. So anyone who chooses to treat needs to have adequate volume to maintain expertise and adequate interest to gain that expertise. So That could be a primary care doctor who works in a prison or in a methadone maintenance program or in an inner city clinic where there's enough Hep C. But for many primary care doctors who don't have enough volume or time to get that information, referral to a gastroenterologist, a hepatologist, or in some cases, infectious disease doctor who has expertise and interest in treating hepatitis C is critical. I think that the capacity is increasing because as the treatments get easier, more and more gastroenterologists and infectious disease doctors who had abandoned Hep C treatment with interferon are ready to re-enter the market. Now that we don't have to do liver biopsies in almost all cases to stage the liver disease, we can use non-invasive markers, both serum markers and increasingly transient elastography, which uses sound waves, or MR elastography, which uses MRI, to estimate liver stiffness, which correlates with fibrosis. We are now going to be able to non-invasively stage the patients and then make determinations of treatment eligibility. So though linkage to care has certainly been a challenge for us, I think it's getting easier rather than harder.